Bismillah ar-Rahman ar-Rahim. Welcome into the next episode of our series of case histories discussion to understand gut-brain axis. Today we shall discuss the second case history, that is the functional dyspepsia patient. The case number 2, functional dyspepsia patient, brain-gut disruption and gastric emptying issues. It's a case history of 45-year-old male, high-stress CEO of a company, and he presented with symptoms of postprandial fullness, early satiety, and intermittent epigastric pain. On workup, no alarming features, and endoscopy was done, which was reported to be normal. The PPIs therapy was tried, and this was with minimal improvement. So 45 years old male, CEO in a company with high stress related posts, and he has postprandial fullness, early satiety with intermittent epigastric pain. On workup, no alarming features, normal baseline investigations, endoscopy normal, and PPI therapies was tried, and it gave only minimal improvement. So why is he still symptomatic despite normal endoscopy and a trial of PPIs? The possible mechanisms for his being symptomatic till now are, despite the PPIs, is disrupted brain-gut communication. This is the first possible explanation. Second is stress and somatization. And the third is overlap with IBS and gastroesophageal reflux disease. Let's understand how the disrupted brain-gut communication can lead to his symptoms and sorts of resistant scenario to the PPIs. In the disrupted brain-gut communication, it involves, or it has a component of delayed gastric emptying, that is the gastroparesis-like functional dyspepsia. And it's common in functional dyspepsia. So in the functional dyspepsia, we see the delayed gastric emptying. The stomach do not get emptied in time. And there's higher vagal dysfunction, and it leads to altered gastric accommodation. So this is another contributing factor, is a component of the disrupted brain-gut communication, which leads to functional dyspepsia. Then stress and somatization, the second component. The functional dyspepsia often overlaps with anxiety, and we see this in everyday clinical practice. The stress reduces gastric motility via vagal inhibition. So there's delayed gastric emptying, and the patients feel full, early satiety, cannot complete their meals. And then there's overlap with IBS and GERD. 30 to 50% of functional dyspepsia patients, they also have IBS, which we discussed in the first case history. So how to diagnose such patients? Of course, the Rome 4 criteria for functional dyspepsia helps here. And consider gastric emptying study if severe postprandial distress is found. So you can do this gastric emptying study. The management approach for such patients includes dietary modifications, pharmacologic interventions, and psychological interventions. So these are the three main components of the management approach towards these patients: dietary modification, pharmacological interventions, and psychological intervention. Let's briefly understand what the dietary modification can help to improve the symptoms of a patient with functional dyspepsia. The patient should have smaller, frequent meals. Instead of two big meals, he or she can have smaller, frequent meals, and avoid fatty, acidic, and spicy foods. Then in the pharmacologic intervention, H. pylori testing and eradication, if H. pylori is found to be positive, it should be tried. Then prokinetics, the procalopride, metoclopramide in the short term, and domperidone. These can be tried and they can help the patient in getting relief from the functional dyspepsia. And of course, the neuromodulators like low-dose tricyclic antidepressants, they improve gastric hypersensitivity. Coming to the psychological intervention, what are these and how we can apply these in the managing patient with functional dyspepsia patient? Relaxation techniques like diaphragmatic breathing, mindfulness, deep breathing, take, breathe, hold in, and then exhale, and mindfulness. This is very important. Then CBT for chronic GI symptoms management, again, it's very, very helpful. So the key message from this functional dyspepsia patient is that for functional dyspepsia, it's not just about acid suppression, that is with PPIs, targeting motility and brain-gut interactions is key. So dear friends, the key takeaways, as always I say at the end of my vlogs on this FGIDs from this case series are that FGIDs, now called the disorders of the gut-brain interactions, are real. They are not psychosomatic. The gut-brain axis dysfunction leads to visceral hypersensitivity, dysmotility, and dysbiosis. The diagnosis is clinical, and this is according to the Rome 4 criteria. So avoid unnecessary tests unless red flags are present. And the multimodal treatment works best. And this includes dietary therapy, psychological interventions, and targeted pharmacology. And the future lies in the microbiome-based therapies, that is the postbiotics, fecal microbiota transplants, gut-specific neuromodulators, that is the serotonergic agents targeting the ENS. So let's continue the conversation. What's your biggest challenge in managing IBS in functional dyspepsia patients? Please share in the comments section below. So thank you very much for being with me. In the next vlog, we shall discuss the third case history to understand the functional GI disorders. Till then, take care. Khuda Hafiz.